So, welcome everybody, and thanks for joining us tonight. The purpose of tonight is like a shorter presentation to talk about Balint groups, and this is a sort of couples, well, plan to run some Balint groups if we get the right numbers through Northside with a particular focus on working with relationships. So. Ballet groups are a particular kind of reflective practice group. So what I want to do is go through some of the history with it, the process, the purpose, and the benefits of ballet groups. Um, and I always like to start with some history. They're called Balint groups based on a guy called Michael Balint, and of course later his wife Enid Balint. And Michael Balint is sort of connected to, he's born in Budapest in Hungary in 1896, and he trained as a physician and later as a psychoanalyst. But in 1919, he attended Sándor Ferenczi's inaugural lecture as the first chair of psychoanalysis in Hungary. And there was a pivotal encounter that shaped his entire career. In 1924, Balint goes into analysis of Sándor Ferenczi, which began a big professional and intellectual clinical relationship that was very strong for the rest of both their lives. Um, Balint immigrated to England in 1938 and initially arrived in Manchester and set up practice there, and then later moved to London. And he became a leading figure in the British Independent Group, which is the psychoanalysts that sit between Anna Freud and Melanie Klein at a particular pivotal point during the war, the Second World War, where there was a split in the psychoanalytic community around traditional Freudian ideas and more sort of developmental, relational ideas, or the beginnings of them. Sandor Fiorenzi is really important because he was sort of Freud's favored disciple, but Ferenczi and the Budapest group developed a much more kind of mutual kind of analytic relationship. And they focused on things like elasticity of the frame, mutual analysis, and all these ideas, which made Freud very, very angry. And he exiled Sandor Fiorenzi, and he was regarded as mad and dangerous and practicing wild analysis because of the foundations of relational ideas that he was working with. And so he sort of disappeared for a long, long time. But Balint was very influenced by him, and this is what we call the Budapest or Hungarian school of psychoanalysis. So, as I was saying, in 1918 to 1919, Budapest was considered by Freud to be the emerging center of psychoanalysis, fueled by Ferenczi's energy and influence. And he held the first chair of a university in psychoanalysis. And Balint got to meet him at the inaugural lectures. The Budapest School emphasized the therapeutic relationship, emotional responsiveness, the analyst's countertransference, and the relational dimensions of healing. So these innovations were quickly criticized, and but actually some people consider them the original birthplace of what we now consider relational psychoanalytic or psychotherapy thinking. And there was a formative bond between Balint and Ferenczi. Balint underwent analysis with him after Ferenczi's death in 1933. Balint brought Ferenczi's clinical diaries and the Freud-Ferenczi correspondence to safety in England. And those diaries did not emerge again until 1985, so they were hidden for a long time and kept safely by Balint because they were kind of considered to be very dangerous and bad. But actually, people started to write from the mid-80s about them, and some key books came out. And there was a re-interest in Ferenczi. And in fact, every year there's a Ferenczi conference somewhere in the world. So, as I said, the key concepts inherited from Balint, from Ferenczi by Balint, were this centrality of a two-person relationship, Concepts like what Balint developed called the basic fault, which is about something missing in early development, and the concept of new beginnings through the analytic relationship. So these relational object relationship ideas directly shaped the Balint group model, especially the focus on the practitioner's inner experience with the patient, which of course was very new and innovative at this time. So this is a picture of Sandor Fiorenzi, and this is a book, I think it came out in the early 2000s. It's edited, you can't see there, but it's edited by Adrian Harris and Stephen Kuchak, and they're two big figures in the North American relational psychoanalytic movement, which is based at New York University. These are the clinical diaries that got published at around towards the end of the 80s. But Ballant, in 48, he moved to London and he began a series of seminars with doctors, GPs, at the Tavistock Clinic in London. And these groups were designed to explore the doctor-patient relationship through case discussion, not clinical material. You can imagine in 1948, it's post-war in London, and there was an enormous amount of trauma around after the war, loss and grief. And also, the GP was a sort of cradle to grave relationship clinician with families and often very poorly resourced. Lots of things were not understood and really known. Treatments were pretty primitive in a way. So the doctors bore a lot of psychological distress with a limited clinical kind of armamentarium or options for treatment. So psychological matters were much more to the fore through that. And Michael Ballant wanted to help GPs manage this stuff. So these seminars were radical at the time. GPs presented cases not for clinical problem solving, but to explore the emotional and relational dimension of their work. So Ballant wrote a seminal book, which is still around today and quite an interesting read called The Doctor, unfortunately, his patient, when it should be their patient, and the illness. And this book came directly out of working with these groups. He observed that this is the famous statement: the drug most frequently prescribed by the GP was the doctor themselves, and this drug had almost never been studied. So there's some key concepts that come through in the book, The Doctor, His Patient and the Illness, around what Balint called apostolic function, which is how a doctor can unconsciously impose their values on the patient. Again, radical at the time. The collusion of anonymity, that's where a patient is not owned by a particular doctor because the patient is difficult and they're sent to different specialists and nobody wants to kind of sort of own the relationship or care for this person that's difficult directly. And the idea of levels of diagnosis, meaning psychological levels of functioning, we would call it today. Um, yeah, so there's just a little side box there about the Tavistock Clinic. It was a psychoanalytically orientated and still is today NHS outpatient centre where the seminars took place. It became the birthplace of Balint groups as an educational format. Enid Balint, which is Michael Ballant's second wife, led the GP training and research course there until 1965, I think it is. Yeah. So this is a picture of Enid and Michael Balint. Michael Ballant's first wife died as soon as they arrived in Manchester. She had a cerebral hemorrhage, and it wasn't until these two met at the Tavistock Institute that they formed a relationship. Um, Michael Balint is the kind of the father, I guess, of Balint groups, and Enid Balint is the mother. And actually, her influence is probably far greater than his, as the idea, as we currently do Balint groups, was probably much more attributed to her developments with it. But she was a social worker, psychoanalyst, and relational thinker, we say today. She co-founded the Family Discussion Bureau, which became the Tavistock Relations, which is what's called today, which they do psychoanalytic couple training in 1948. Yeah, so she co-founded the Family Discussion Bureau in 1948 to train social workers in couple and family work, where she first met Michael Balint. She trained as an analyst under Donald Winnicott, actually, and she married Michael Balint on the 2nd of January 53, beginning their intensive research and clinical collaboration. So I think we've said that she ran the research and training group. Michael Balint died in 1917. She continued his work, leading the British Psychoanalytic Society, fostering the international development of Balint organisations and the International Society, Balint Society, which continues to meet annually somewhere in the world. And there are societies all over the world, part of the Australian New Zealand Balint Society. Um, I believe in the UK there's a conference, a Balint conference held every year in Oxford. Um, so this is a picture of Michael Balint. These are a couple of the books that he wrote. Sorry about that. The Basic Fault and the Doctor, His Patient and the Illness. Just thought I'd put those there. So the next thing that we want to move on to is, so what are we doing in a Balint group? What are we focusing on? And the central object of inquiry in a Balint group is kind of like the doctor, his patient, and the illness. What we're looking at is the client, the therapist, and the relationship in between. So we're looking at the practitioner's inner experience with a particular client, the feelings, images, body sensations, confusions, and impasses that arrive in our direct work with our clients, the relational dynamic between practitioner and client, what is happening between them that is difficult to articulate or resolve. We're looking at the unconscious dimensions of the clinical encounter, what is being communicated beyond words, including affect, metaphor, and enactment. Stuck cases are very good Balint cases, clients who stay in the mind to provoke unusual responses or actions in us who seem impossible to help or who inexplicably disappear and leave. The practitioner's countertransference is a focus. We describe it in plain language as what the case evokes in me rather than use clinical jargon. This is a really big thing with Balint groups. We don't like to use clinical jargon, but more on that in a minute. Expanding the group's collective understanding of the human dimensions of clinical work through free association, imagery, and creative thinking. So they're the things we're really wanting to focus on. Obviously, with a group where we're kind of harnessing unconscious material, group agreements and the basic contract is very, very vital. And these things are pretty obvious to many, many people, but we talk about, the agreement of many factors, time boundary. We talk about member confidentiality and client confidentiality and the confidentiality of the space. A key thing with Balint groups is that there's something vulnerable in presenting a case in a Balint group, not too vulnerable, but it is a bit vulnerable. And so we can be inclined to focus on the confidentiality of the clients that are mentioned in the group, but actually we have to hold confidentiality for all members of the group and the presenter because they bring things of themselves in and they're confidential things. So we're very strict about that. For example, people might be friends that attend a Balint group, but we ask them never to discuss the cases outside the room or the group itself, just to keep the sanctity and the protections for presenters in the group. We have to have agreements about technology and ensure it all sort of works. That seems pretty obvious, I know. And the thing is, and I'll speak more about this, that Balint groups are not process groups. They're not therapy groups and they're not process groups. So any difficulties that one experiences has to be handled between the group member or presenter and the leader of the group, and they do that offline. So key things with the agreement is we always speak on our own behalf. Everyone has a job as a working group. That's what we are. We don't diagnose, we don't solve problems. There's no clinical judgment, and there's no jargon, or we avoid it as best we can. So we say everyone has a role in a Balint group. Each participant carries a distinct function in the group's work. It is what we call a working group, so our focus is on cases. It's not on process. So the leader's job which would be me if people decide to sign up to doing this, is to hold the frame. So that's time, confidentiality, and safety. The task of the leader is to what we say call for a case. So that's to ask if there's anybody here today that would like to present a case as something that they would like to hand over to the group. The job of the leader is to also protect the presenter. So that's offering care and kindness, a paramount. As the leader, you're always observing the presenter, making sure they're okay. You may intervene to protect members of the group as well, to keep the group to task. Remembering what we say is that the task of the group is to think in the position of the client or think in the position of the therapist. We don't, and everything that we say, we sort of bring it in through those roles. So it's not like we say, I think you should have done X, Y, and Z in that situation. You have to sort of formulate it in a way that you say, if I was the client with this therapist, I'd be feeling X, Y, and Z. You don't actually directly tell people what they're doing or what you're thinking about what they're doing. So in that way, you kind of stay within the kind of confines of this, the client, the relationship, and the therapist. So the leader also has to facilitate without directing the content of associations. We're really trying to promote everyone thinking very freely in the group, and so you kind of have to direct the group in terms of balance. Sometimes when a difficult client is presented, the group will be really keen to over-identify with the difficulty of the presenter. And so you'll get lots of people saying, if I was the presenter, I'd be angry with this client, or if I was the presenter, I'd just feel like I had no options. And then we might get overbalanced in that direction. So the job of the leader would be to kind of bring people back. So what would it feel like to be in the client's position in this story? And so to sort of, we've got to get that balance, and that's part of the leader's responsibility. It can't all be weighted in one direction. As I said, we address problems offline and we keep language jargon free. So the presenter brings a case, and it's a story about themselves and a client. It's not a comprehensive case. We don't bring a case history. The person has about 5 minutes to present, and they're presenting a moment of an experience off the top of their head that relates to this client. It does not have to be comprehensive, and in fact, it's sometimes better that there's less said, because we're wanting to get the group to speculate and use their unconscious associations to the case rather than be sort of filled with facts and details. So it's off the top of the head. It's a very brief description of the situation. It often involves a little vulnerability, which is met with care. The brief factual questions are allowed. I'll show you that in the sequence in the next slide. Once the presenter has presented the case, they're sort of pulled back out of the story. I'll show you that in the next slide as well. And then the presenter just listens to what the group does with their case. And then at the end of the case, the person will return. And if they would like to speak about how they were affected by what the group did with their case, or things that were missed, or extra details, sometimes they bring those in, but the person can choose not to say anything if they don't want to. The group's role is to listen carefully to the case, and we say with mind and body. So we're looking for associations within ourselves, feelings, images, metaphors, songs sometimes come up, symbols come up. And we say that sort of listening with the body and listening with the unconscious in a way. And we encourage people to bring these things up. They don't have to be connected to what someone else is saying, but it's kind of sometimes a pattern gets going where there's a kind of riffing off each other kind of experience, which is when there's a lot of trust in the group and there's a kind of confidence to sort of let the unconscious go a bit, and that can be very powerful. So we say that as a group member, we speak on our own behalf. There's no expert pronouncements. There's no need to agree or disagree with other contributions. Nobody's right or wrong in this experience. We hopefully riff off each other's associations. All contributions are considered to be valid, and our responsibility is to be engaged in working the case as part of this group. And also, once the presenter is called back in, we don't return to the case. So once the case is closed, we're very strict about that. We don't extend our talking about it. We let the presenter tell us what they've experienced of the case, and that's where we leave it. It's another containing function of the group. So just some of this is a repeat of the last slide, but it's just to give you a sense. When we open a Balint group, if we've had some cases before, the people that have presented in the previous meeting, they're invited to kind of talk about whether there is anything to follow up about the case. What's really interesting is when a Balint group gets going really well, you present a case and you're often seeing that person the next week or perhaps the week after, and just the group working the case, something is relieved within us and something shifts. And people frequently talk about the next time I saw Mr. Smith, it was quite a different experience. And I felt really more comfortable about being a little confrontational, or I felt better about taking my foot off the accelerator with the situation. They'll often bring positive experiences that came out of the group. So we'll often do that first. And then once that's done, that's quite brief, then the leader calls for a case. So the leader invites a group member to present a story about themselves and a client. Once that's established, generally in an hour and a half, this may be different when we do couples work because we have can have two or more clients in one case. So we might extend them and do them a bit longer and maybe do some reflection, extend the reflection at the end, maybe. But generally we do two cases in an hour and a half. So often at the beginning of the meeting, you'll establish, okay, Jenny's going to do case one and Philip's going to do case two. So then we go to the first case and the presenter shares briefly, not the full case history, a snapshot, a feeling, a moment, or an impasse about a situation. Once they've sort of said enough, the leader might say, okay, I think that's a good place for us to stop. Now let's bring in some factual questions, and that's the next step. And we do that for about 5 minutes. And sometimes the leader will say, actually, I think we've got enough to work from. Or we might have a few factual questions that the people might want to ask to fill out some detail. We're not allowed to ask relational questions or anything to do with transference or countertransference in those questions of fact. It's only questions like, is their mother alive? Do they have siblings? How long have you been seeing them for? Very concrete details. And then we'll bring that to a close. And then what happens is that the presenter is then pushed out of the group. Now, when you do it in a live group, you do it in a circle, and then the group is sort of opened up, and the presenter who's sitting in the ring of the circle of the group, they push their chair back, and the group closes up with them outside because their job is to hand over their case to the group. And then once that's done, the group works the case for about 25, sometimes 35 minutes. So that's where the free associating to the story comes in, the feelings, images, metaphors, songs, that sort of material is brought forward. And the leader gently directs people through this process, remembering that there's no need for consensus and agreement and all contributions are considered equal and valid. Once that case is, the leader says, okay, I think we can bring this case to an end now, and we'll bring our presenter back in. The presenter returns, and the presenter is asked if they would like to respond to the group or say something, but there's no cross-examination or returning to the case at that point. So what makes a good case to present? Well, I think I've said some of this, but a case is a snapshot. It's a story about you and your client, a situation, a feeling, an inner conflict. It's a moment, an ending, an off-guard moment, cases that can hinge on something very small. Like, for example, recent one I was in, one of the cases was about a throwaway line by the client that offended the presenter, who was the therapist, and they didn't quite understand why. Another one recently was when a client was leaving and they spontaneously hugged the presenter. And that sort of threw the presenter. So things like that, there can be little moments. The client who sort of pops into your head and it's valid. The client who simply pops into your mind is as valid as the most clinically dramatic cases. So sometimes when you're sitting there thinking, oh, do I have a case to bring? Someone might come into your mind, and that's often a sign that that's a good case to do. Cases often carry a little vulnerability in the presenter. This is respected and met with care and kindness. The case involves a snapshot of the client and the therapist and a sense of what is happening between them. Cases are often brief, sometimes very short indeed. Things to keep in mind. Don't present a case you are not willing to hand over to the group. This is really, really important. If you feel really troubled about the case and you're not sort of you're feeling unsettled, like in a way that something in you says don't present it, then don't present the case. You've got to be really willing to hand it over and have the curiosity for the group to look at the case, and that's a kind of judgment call you have to make within yourself. Some cases can make us feel too vulnerable, so we just have to be careful about that. The goal is not to have the group solve your clinical problem. You do not need to have all the answers. Uncertainty and confusion are welcome in presenting a case, I mean. It doesn't require a particular outcome. Even a good session can be a Balint case. The patient who makes you feel stuck, confused, angry, sad, or unusually elated is worth bringing. Trust yourself. If the case came to mind when the leader called for one, this is meaningful, we say. Um, okay, I think I've talked a bit about this. What we're talking about with the group is a sort of freedom to free associate, use imagination, and harness what we call the group unconscious. So we say association over analysis, so just links you're making in your mind rather than an analytic, verbal, concrete thing. Metaphors and symbols, it's amazing the visual things that come to mind as you're listening to the case. I can think of experiences in myself where I felt like I've had a vision of being miles out at sea, dog paddling and no kind of contact with the shore. The shore just seems so far off. This is really interesting, and as a group member, you might not understand what that means or what it's about, but you would bring it in because somebody may be able to pick it up and make a connection to it. So that's where you're riffing off each other. As I said, no consensus is required. We avoid jargon and we don't diagnose the problems. So this is what a Balint group is not. I think I've said this. It's not group therapy. It's not a process group. The Balint group's focus remains firmly on the clinical case, not what is happening between group members. Um, some groups have found this particularly leading with doctors, I have to say. They can be quite competitive. And it takes quite a lot of containing by the leader when people sort of get competitive in the group. But as most of you will probably know, groups have their norming, forming, and storming stages, and some of that has to be worked through as part of the Balint process to get there. But the structure of it is designed to contain and reduce that level of competitiveness. And we say there's no problem solving and there's no teaching. It's not about teaching anybody anything or showing what we know and being competitive in that way. In summary, a Balint group is a confidential, non-evaluative, reflective space in which practitioners explore the emotional and relational dimensions of their clinical work through free association, metaphor, and the imagination of the group. There's been 56 studies in a meta-analysis last year. 45, I'm sorry, where are we? Give me. So, and there are benefits. There's some research showing that they reduce burnout. They definitely improve communication. Practitioners report greater ease in difficult consultations, particularly after presenting at Balint groups. It helps with professional identity. Participants report a stronger, more nuanced sense of professional identity, particularly helpful for practitioners navigating ethical complexity in paths and endings. The group cohesion and support is really phenomenally powerful. When people present cases and you have this sort of identification with the experience of the case, it's helpful to everybody. You find that like people present cases which you so relate to, and it's such a relief to know that others are experiencing the same sort of dilemmas. And when people get confident and trust builds in the group, we get to reveal more and more of our conflictual situations that we find ourselves in. Whereas often there's a kind of shame element with that. And I think Balint groups can really get us past that when they're run well and there's a sense of safety in the group. That's been shown to increase empathy and obviously reflective practice, developing the practitioner's capacity to think about their thinking, to observe themselves in the clinical encounter without self-attack or excessive anxiety. There was a paper written recently by Fonagy and others about whether Balint groups are around giving clinicians the opportunity to mentalize and improve their reflective function. And I think there is a lot of benefit in that. So this